giant cell granuloma was given by Jeffrey, who coined the term central giant cell reparative granuloma, from which reparative term was later removed because it's a destructive lesion. Then coming to its basic structure, that's the benign, proliferative, non-neoplastic, and reactive lesion. Coming to its etiology, it might be caused by the developmental disturbance of bone, infrabromic trauma, which might cause hemorrhage, abnormal bone repair, and then conditions like fibrous dysplasia, Paget's disease, and ossifying fibroma. Okay. Then coming to the clinical features, it might be seen mostly in the young people less than 30 years of age, females. Mandible is mostly involved, anterior region is mostly involved. Then coming to the different types of lesions, so it might be a non-aggressive or an aggressive lesion. So the non-aggressive one is usually slowly growing and may be discovered accidentally, so it causes root resorption or perforation is absent and formation of new bone. And the aggressive lesion is quickly growing and shows pain, and either there might be no signs and symptoms and discovered accidentally, or there is cortical expansion and perforation, mobility, displacement, and root resorption. And coming to its borders, so according to borders, it can be of two types: the regular borders or the diffuse borders. Then coming to its radiographic features, so it might be a destructive lesion, mostly a destructive lesion, and a radiolucent area is mostly present with either smooth borders or rag borders. Sometimes faint trabeculae might be present, and the large lesions are usually multilocular. Then coming to the 30% cases which have a thin cortical bone and expanded, causing a perforation. Then coming to the histological features, so WHO defined central giant cell granuloma histologically as intraosseous lesion consisting of fibrous tissue containing multiple foci of hemorrhage, aggregations of multinucleated giant cells, and occasionally bony trabeculae, and loose fibrillar connective tissue stroma with interspersed proliferating fibroblasts and small capillaries. So the treatment plan is as follows: curettage, surgical excision, and lesions fill with new bone and heal with no difficulty when curettage and surgical excision is done, and only local curettage has 70% recurrence. En bloc resection is indicated for large aggressive lesions. Radiotherapy is contraindicated, and subcutaneous calcitonin injection or intralesional steroid like triamcinolone is usually given along.